Good afternoon, everyone, or evening, I should say. We're here in DC, so it's 6 o'clock. My name is Suzanne Robertazzi. I think I know most of you. I am a nurse practitioner that works out of the Washington, DC VA Medical Center. And tonight we're going to continue our lecture series, and tonight's going to focus on really MASLD and MetALD. So we kind of started the series talking more about MASLD, and now we're going to kind of end on a new note, adding basically MetALD and how to diagnose that and find that in your patient population. So we'll start with a nice case. So this is probably someone many of you seen in your clinic. I know at the DCVA we get evaluations for this all the time. So this is Ashley. She's a 52-year-old woman. She was referred for evaluation after having an abdominal ultrasound that showed some mild hepatomegaly and really some increased hepatic echogenicity consistent with steatosis. She feels fine. She has no complaints. So she's probably wondering, hey, why am I coming to your clinic? But this is very common. You know, we get referrals in our liver clinic all the time for folks that have steatosis seen on ultrasound. So we see her in the clinic. We get some medical history. We see a couple of things that stand out. She has a history of PCOS. She has a history of hypertension and hyperlipidemia, so those kind of raise some flags for us. You can see on medication, she's on amlodipine and atorvastatin, so she's being treated for her hypertension and her hyperlipidemia. She takes a multivitamin. She's on milk thistle, someone probably told her it's good for her liver. On physical exams, she has a smooth, non-tender liver edge. And then when you get to her social history, she does self-report that she drinks about 2 glasses of wine a day. So that also should kind of raise a little flag when you're thinking about your assessment. Then we get some blood work in her vitals. You can see she's got a little bit of hypertension. Her blood pressure is a little bit elevated in clinic. 140/78 may just be related to being in your clinic. Her BMI is slightly high, so she's got a BMI of 29. Also should raise, kind of put that in your pocket. And then her AST and ALT are both elevated. You can see her AST is a little bit more elevated than her ALT. Our platelet count is okay. Hemoglobin A1C is okay. But then you also see her triglycerides are mildly elevated, so 185. Which would also keep something we've got to keep in mind when we're thinking about her case. So then we go to the all-important FibroScan, which we have at the DCVA. I'm sure a lot of other hepatology offices have it. So we're going to do our FibroScan, and we can see here that when we get our results, we can see that she's got her KPA is 11.4. So that really brings her in the significant fibrosis, that F3 category. And then her CAP score, which is a marker of her steatosis, is also very elevated. So that brings her in the severe steatosis. So we've got a patient with significant fibrosis and severe steatosis. So when we think about steatotic liver disease, we've kind of seen this graph before in our prior lectures. We're going to really focus on that middle part, the MASLD and increased alcohol intake. So we know she has steatotic liver, right? We saw that on ultrasound. We see that in our FibroScan. That kind of confirms that. And then what we want to figure out is kind of associate where she falls into. Is she a MASLD, a pure MASLD, alcoholic liver disease alone, or is she a combination, this MetALD? And when we think about it, with her alcohol history that she self-reported, we kind of have to fit her in that ALD category. And then subset of that is she MASLD predominant, or is she alcoholic liver disease predominant? And you can see on the score there below, on the left-hand side, if they're self-reporting their average daily intake. And you have to think about this. The first number is for women. The second number is for men. So women can't drink as much as the men. So we'll see. So 20 grams of alcohol intake a day for women would be MASLD predominant. And when you think about alcohol content, the next slide will show us, but 1 drink is 15 grams of alcohol. So when we think about our woman, she's reporting 2 alcoholic drinks and she's a female, she would kind of fall over here into the middle. So she's drinking 30 grams of alcohol. So this is kind of a good graph to kind of make sure that when we're assessing alcohol intake, we're all kind of, when we're talking with our patients, we're all talking on the same page. We're all giving the same, reporting the same amount. So when you think about, I have, a glass of wine, really 5 fluid ounces of table wine is considered 1 serving of wine. So it's important to make sure, like I said, when you're assessing your alcohol intake, you're kind of both speaking the same language. A glass to you is a glass to me. Or for beer, we can see here, it's like 12 ounces. We want to make sure that that's the same, the same thing that our patients are thinking. So it's important to know from the beginning kind of where we are with our alcohol intake and make sure we're all speaking the same, thinking about the same quantity for that. So really, when we think about risk factors for NAFLD, which we've kind of talked about in previous lectures, we know insulin resistance, diabetes, obesity, having that visceral fat, unhealthy food, sedentary lifestyle. There is some genetic susceptibility. And then when we combine alcohol with that, we can see that, as this cartoon projects, it really accelerates the fibrosis and disease progression. So we have to make sure that we're not missing this key important kind of factor when we're evaluating our patients, because it really can affect their long-term prognosis and kind of affect how we're going to treat patients long-term. And this is a nice kind of graph. It kind of really shows us, when we look on the left-hand side, we can see both the fibrosis stages. And on the bottom, it kind of we have a spectrum of disease, right? We see our MASLD patients to the left, then we have our MetALD patients in the middle, and then our alcoholic liver disease patients on the right-hand side. And you can see that a patient, let's say with F1 fibrosis, their 5-year risk factor for having any decompensations is less than 1% when they have pure MASLD. But if they have alcoholic liver disease, we can see that that 5-year risk factor increases, right? 2 to 15%. So that's a big increase in your risk factor for decompensation. And then when you look at the top one, that even increases even more when you have patients with like F4 fibrosis. So F4 fibrosis with alcoholic liver disease, you have a 5-year risk of decompensation up to 50%. So it's really important that we're not missing these patients, or we're not missing that alcohol component, so we can really educate our patients and give them kind of a full spectrum of what their liver disease, what their risk factors are. So detection, so how do we find out, how do we determine alcohol use? And we obviously have self-reporting, which is great, but we have something, we use at the VA is called the Audit C. It's basically 3 simple questions. How often do you have a drink containing alcohol? How many drinks do you have per day? And how often do you drink 6 or more drinks a day? And each question you get kind of points added to it. It's a very simple question. We do it in our clinic, 3 questions, and it kind of gives a good understanding of how much people self-report their alcohol and how much alcohol use is kind of a marker and can be affecting their health, overall health. We also have blood work tests. You can look at their MCV if that's high, GGT. There's urine ETG, which is also a great biomarker, and even hair ETG. In this study, this was a study kind of looking at patients who were classified as NAFLD or MAFLD patients, how many had an alcohol component that maybe was missed or maybe was not seen, thought of originally. And you can see here, like up to 28% of NAFLD patients have reports of excessive alcohol consumption. So it's pretty significant. It's a big chunk of patients that you don't want to miss, that you don't want to kind of have not giving them proper education on their liver disease. And then here, this just talks about kind of how accurate these testings are, which we know that they are accurate. We kind of talked about how we can miss the alcohol component of metabolic liver disease. So again, this is another nice flow chart. Talks about steatotic liver disease and how we can kind of go through and make sure that we're correctly classifying these patients. So we know we have evidence of metabolic dysfunction. So again, there's those 5 key points of BMI greater than 25, elevated fasting serum glucose, elevated blood pressure, elevated triglycerides, and an elevated HDL. So the thing that we have to remember when we're looking at this is this an isolated incident? Is this one reading that showed the triglycerides being 180? Or is this kind of on a spectrum? Are we seeing this more than one time? Same with blood pressure. So was there just one blood pressure reading that was elevated, or are we seeing this more consistently with their office visits? So we see here, if it's just one isolated reading and they have no evidence of alcohol use, then yes, you can classify them as MASLD. But key is to kind of be alert and see, hey, your triglycerides were totally normal. You had this one elevated reading. Is this someone that we should use maybe PEth testing for, or some alcohol biomarker to kind of capture that patient and capture that alcohol use? So they say, no, I don't have any, I'm not disclosing alcohol use, but you get a positive PEth, then we've got to reclassify that patient. So that's where you can see that you may misclassifying a patient that has MetALD if you're not kind of doing a thorough assessment. So for our patient, going back to our patient, we're going to order a PEth test for her. We're going to let her know, hey, we're going to order this PEth test. We get the result, and it's 120. So it's an elevated PEth test. It's kind of consistent with more moderate to heavy alcohol consumption. So that's a big piece of information that we have, which we will then kind of go back to. But what is a PEth? So PEth testing, something that's been around for a while. It's a blood test that we use. And you can see that when you look at this chart, you can see the blue line is the PEth testing, and that gold line is really a blood alcohol level. When you look on the left-hand side, that they just drank it, maybe had just had a drink, and you can see that the blood alcohol level will go up, rise right away, right? That's what we expect. After 10 hours, we'll kind of trail off, or even 8 hours. But that PEth test will continue to rise. So really, PEth will detect alcohol use for 3 to 12 days after just maybe even one single binge. So it's really a nice test to look at kind of more if you're worried about kind of monitoring alcohol use and you're not really catching someone right after they've had a drink. Not catching, that's kind of the bad word, but understanding that. And we can see that there's really no variability you can have between men and women or BMI. None of that can affect the kind of results you get. So it's a good test to kind of quantify alcohol use. And then we'll go through this. This is another study. This was a cross-sectional study. Really it was enrolling patients who were labeled as overweight or obese. And they went through and excluded other things. So if they didn't meet the age inclusion or BMI inclusion, or if they had other liver disease, they were kind of excluded. And if there were patients that were never drinks or had missing data. And really, when we look at it, the main point of the study was to show that these patients may have been classified as metabolic liver disease, but 15.7% of them were at risk for MetALD. So that's showing you that you really have to make sure that we're asking the right questions and we're getting the right tests to make sure we're classifying these patients correctly. So even though they may have many metabolic risk factors, we want to make sure we're not missing any other risk factors for liver disease. So going back to our patient, we see that she has this history of hypertension and hyperlipidemia. So that'll kind of bring us back. We got her PEth scan. So then what do we do about that hypertension and hyperlipidemia? What do we want to make sure that we're recognizing? This is just a Cochrane review that was done in 2020. It's kind of interesting. They looked at 32 controlled trials, and they're looking at how alcohol affects blood pressure, and they compare it to placebo. And you can see here that overall, alcohol will decrease blood pressure up to 12 hours after consumption, and then increase blood pressure greater than 13 hours after consumption. So really what they want to make sure is is that you don't want to label, you want to make sure that the hypertension that you're putting in someone's chart is true hypertension. It's not related to, basically in this case, alcohol use. And the same thing with hypertriglyceridemia. We saw that our patient had an elevated triglyceride level. Now, they only gave us one level, but it was elevated. So we want to make sure we can see here this little bit of a busy chart, but basically on the left-hand side, we can see that on the top, it's people who have been labeled as folks that have high triglycerides. You give them water, which is the gold, and then you give them alcohol, which is the blue. And you can see that those patients who were given alcohol had a rise in their triglyceride level. You see the blue line goes higher than the gold line for water. And even when you look at patients who have not been labeled or have not had a history of high triglycerides, again, give them water, the triglyceride level stays the same, but you give them alcohol and you can see that blue line goes up, right? At 4, 6, 8 hours after they've had an alcohol drink. And then you can look on the right-hand side here, and it shows similar results, but you can see that the group that was not labeled as having high triglycerides, when we gave them alcohol, the percentage change from their baseline was very high, right, for their triglycerides. So you can see that curve is really much higher. So it's just something to keep in mind that when you see one reading of a triglyceride level in a patient that has alcohol use, you want to make sure that you're really understanding if that triglyceride is related to like recent alcohol use. Okay, so we'll go back to our case. So here's Ashley again. So we've collected kind of a lot of data about Ashley. So we've got our lab work, which we kind of already reviewed. We see that our AST and ALT are elevated. We've medications haven't changed at all, which is and her alcohol. We know kind of key things that we want to look at, right, is her alcohol use. So that 2 glasses of wine a day, that's 30 grams a day for women. So that's marking her as more. We have to worry about her alcohol use. We saw that she's got F3 fibrosis and she's got an elevated CAP score. So we know she has metabolic liver disease, but are we going to add with her we're going to add with her alcohol liver. So she's got metabolic steatotic liver disease, but predominantly on the alcohol side because of that self-reporting of her alcohol use and her positive PEth, which has kind of confirmed her alcohol use. So what do we do? So we went through, we've kind of come up with a diagnosis, and then how are we gonna help her? What are we gonna educate her on her and how she can kind of improve her liver health? So diet. So similar to what we've talked about with metabolic liver disease, we're going to talk about diet. So we know the Mediterranean diet has the most research and effectiveness in trying to help patients with steatotic liver disease. We're going to recommend exercise. We know that everyone should get 30 minutes of exercise a day. This becomes very important when we're trying to kind of reverse steatosis in the liver. And weight loss. So we know that she is considered overweight, so we can help her with her weight loss. She a candidate for resmetirom? Yes, she is. She does not have cirrhosis. She could be a candidate for this medication. So something we'd have to work with her insurance company, make sure we can get. And in regards to her alcohol use, yes, we're gonna recommend that she stop using alcohol. Now, for some people, that could be simple. For others, it may not be such a simple task. So we can work with our mental health providers to try to help understand her alcohol use and kind of help guide her as to why we're having her stop her alcohol use. I work in transplant, so alcohol use can be kind of more of a driver, but we want to make sure that we're kind of giving her all the resources to be able to cut back her alcohol use and hopefully stop it completely. And then the question comes, does she need HCC screening? Her primary care wants to know, hey, would we have to worry about liver cancer? Yes, you do. We know she has F3 fibrosis, so that's someone that would be at risk for developing hepatocellular carcinoma. So she would need to be screened every 6 months with either ultrasound or cross-sectional imaging. So when we talk about MetALD and we're looking at clinical trials, right, we're trying to help offer patients the best way we can to kind of treat them. We want to look at a lot of things we have to look at is basically having an objective biomarker. We want to be able to truly assess patients' alcohol use. We know that there's a chance that patients can underreport their alcohol use. So we need an objective way to be able to measure alcohol use. We also need to standardize what their recent alcohol use is, right? So you want to make sure someone says like, oh, I haven't had a drink in 3 months, or I haven't had a drink in the whole month. You want to be able to confirm that, what the patient's saying. So you need really objective biomarkers. And then someone says, I haven't touched alcohol for 6 months or 3 months, whatever. Again, you want to be able to have a way to measure their alcohol use, kind of confirm when they say they've been abstinent. You also want to make sure that the other drivers of liver disease are present, right? So we want to make sure that they have more than one cardiometabolic risk factor, or we want to make sure that diagnosis of hypertension or hyperlipidemia really remains after they've stopped their alcohol use, right? We want to make sure that the alcohol wasn't causing that hypertension or causing that hyperlipidemia. So after they've stopped alcohol, we've confirmed that they're abstinent. We want to make sure that that blood pressure is still elevated, or if it isn't elevated, make sure we understand that. Consider exposure to risk factors. So we know those risk factors that we talked about for MASLD, we went over those. So we want to make sure that they still have those risk factors during the last 6 to 12 months or whenever they've stopped their alcohol use. So really a couple of take-home messages that we want to make sure that you guys understand. There's a new definition of MetALD. So really you're confirming that they have metabolic liver disease, and then you're assessing basically their alcohol intake. So for women, it's basically if you have more than 1 drink a day, so that would be considered a diagnosis for MetALD, or for men, they can have up to 210 350 grams. So that would be like 2 drinks, 2.5 drinks. You want to also know that some like historic clinical criteria could underestimate how many patients have MetALD. Like we saw that in that study that there was like 15% of patients that they missed that got diagnosed with metabolic liver disease but didn't have that alcohol component. So you want to make sure that you're not missing those patients. Use of alcohol biomarkers. PEth testing is a great way to kind of understand someone's alcohol use and kind of quantify it. You want to ensure that the drivers of liver disease are present, and you really want to reassess those metabolic dysfunctions over time. So you've got your patient, you've educated them on kind of alcohol cessation, you've confirmed that with PEths that have been negative. You really want to make sure that they still have those metabolic dysfunctions that they were labeled with or had prior to when they were using alcohol that are still present. Consider adequate exposures to risk factors. And then finally, like we talked about, making sure that we have really an objective way to measure MetALD and get that diagnosis, and really so we can compare among different sociocultural categories. So you want to be able to have a way that we can study these patients, objectively diagnose them, so that way we can work on treatments to be able to help cure them. And then this is a great, if you want to take a picture, this is part of the GAP MASLD Community Network. There's also other lectures that you can see from other APPs in our group and different webcasts. There's a lot of great education on this platform. I finished a little bit early, so we have some time for questions if anyone has any.
Hey, Suzanne, this is Patrick Horn from the University of Florida.
Yeah.
Great presentation. Thank you. I wanted to ask you, with PEth, do you routinely screen all of your MASLD MASH patients with PEth, regardless of their reported alcohol use? Just kind of building on your point about, trying to get most objective measurements and what one person considers a glass of wine, another one may not. So I wasn't sure if a PEth is something you routinely order on all your MASH patients, or just those that you sort of have a high index of suspicion may have either ALD or MetALD.
Yeah, I mean, I think definitely it's a conversation I have with them that I would order it, but I usually, full disclosure to the patient, like, hey, we're going to order this, because what you don't want is someone to be like, I didn't know you were testing me for that, and then it can kind of break the. So yes, we do. And, I do a lot of transplant care, so it's something we do even after transplant, but really being open, like, we want to do what's best for you. We're going to get this. So we use it a lot at our VA. And I don't know if it's also, our patient population is a little bit different. Being veterans, there's kind of a lot more mental health issues that we see too. So, we may skew more that way just because of kind of our environment that we work in.
Great, thank you.
Well, thank you everybody for joining us. I know some of you have come to this is the last of the lecture series for me, but I really appreciate you guys coming in tonight and joining me. Please, I think Carol and Wendy, I know you have my email, so if there's any questions or anything, please let me know. I'm always happy to answer anything.
Thank you all.